So I'll pass these around just so you can see. I'm kind of far. My name is Pamela Avery. I'm an RN, and I guess I'll be teaching you, it's really informal. I'm going to be teaching you about trach care and G-tube care, because that's the majority of your patients, I guess. And so I'm going to pass these around. These are just for your visual, because sometimes it's, you know, it's easier to learn by looking than just listening to me talk or watching a, we're going to try to get the video up. That's also helpful. But just so you guys can get a feel for it, I'm going to pass these around. I'm going to show you how to do it, and then you guys can, like, you know, practice, and if you have any questions, you can ask me or any one of us. Okay? This is Gadet, and this is Janice. She's an LVN. She's the owner of a home health company. Okay, so how many people have dealt with trachs before? Okay, do you guys suction through them? Like, what do you guys do, the trach care and everything for them? Oh, okay, pretty much. Okay, so this is, do you guys use sterile gloves, or this is a sterile technique? Okay, so you want to set up your sterile field. So here, I don't have any sterile gloves, but, so you want it, this will act like your sterile field. So when you're, you know, obviously, you know, general practice is to wash your hands prior to coming into the room. You want to don gloves. When you do, oh, thank you. So you wash your hands, you don gloves. So this will be like your dirty gloves before your sterile technique. So you want to take your gloves, and just like normal, after you wash your hands with soap and water, you want to do this, and you obviously introduce yourself to the patient. You let them know what you're going to do prior to doing it. This is all stuff licensing is going to ask you. I know it seems like real, you know, like, oh, okay, of course I'm going to, you know, introduce myself, but they're going to ask you. You know, so introduce yourself, tell them what you're doing, and then this will act like your dirty gloves. So obviously you're going to have like trach dressing around, and you're going to want to do your dirty stuff first with your dirty gloves. So you want to take off the dressing that you have that's already on there, and then you take this off. Okay, so then that'll be your dirty, and then you can use hand sanitizer, or you can wash your hands again if you want. So you open up your sterile field, so you go like this, and at this point you don't even have your gloves, because your gloves should be in here normally, right? If you don't have it, you can have it to the side, then you do your sterile gloves here on your sterile field, right? So you open that, you don your gloves, and then you take the pieces out. So this is close, like this is at a bedside table or whatever table you have. So you have this is your drape, and then you put this to the patient. Do you want to be my patient? Whatever, that's okay. All right, so let's pretend this box of gloves is my patient. Okay, so then you take the pieces off. So, are you guys familiar with everything that's in here, pretty much? Yeah? No? Okay, so you have this, you have these little clippers. I'm gonna be honest, I don't even use that. I don't know what it's for. So you have, there's a lot of things in packets that I have no idea what it is for. So it comes with 3 Q-tips. This is to clean the stoma area around the flange. The flange is what holds the inner cannula. So this gets into the deeper sides, like within and closer to the stoma. So you have 3 of these.
What are you putting on the tip to clean?
Okay, so yeah, so well, you take this off right here. Like you take all of this out of this. This is your container, and this is where you're gonna put your liquid to clean. So it's gonna be half sterile water. It's a 50-50. So you have sterile water and half hydrogen peroxide. Okay, the ratio is 50-50, whatever it is. okay? So you put that there, you pour it in, okay? So you have all of your stuff. So I like to lay out my stuff here, like this. And then it also comes, this is also useless, I don't even know what that's for. So you have like these little pipe cleaners, and then you have this one. This is what we mainly use, because it's fat and it gets into the inner cannula fairly well. So this comes with one, and it's, to be honest, it's pretty flimsy, right? I mean, this is like, it's not very stable, but I don't know if your facility provides these.
No, it would be the families.
The families, okay, so I'm sure they have this. So see how like flimsy this one is compared to this one? This is a lot thicker, and this one comes in like 2 per packet. So either one is sufficient, but this one's a lot better, because if you have drainage around your stoma, this will catch it. This one you'll have to change like, I don't know, every 2 hours or something, because it'll be soaked pretty well. So it comes with one, and then it comes with like three gauze. And this one you can wipe around the skin around the area, or around the stoma. Now, you do not want to use this solution on the skin itself. This solution is only to clean the equipment. So the inner cannula and then the flange around it, but not the skin. The skin you can do soap and water. Honestly, you can dip this in soap and water, and or like saline at most, right? So you do this, and then you just pat it around there. Okay, so here's the inner cannula. Okay, so most of your patients are on room air, right? They're not connected to a ventilator or anything like that, right? Okay, so taking the inner cannula off sometimes could be very daunting, because you're like, oh my God, they can't breathe. They're on room air anyway. So taking the inner cannula out is not going to be a problem unless they're connected to a ventilator. If they're connected to a ventilator, then you're going to have to pre-oxygenate them first, and connect the tube back so they get air while you're doing this, okay? So because they're on room air, it really doesn't matter. So getting back to what I was saying, so you put the 50-50 solution in here, right? So when you're taking this out from the patient, you have your, when you touch this, this is your dirty hand, right? This one is your sterile hand if you're right-handed, and vice versa if you're left. So let's say, so you're touching this, and you're like, okay, so I'm gonna take this out and put it in here. Okay, so you're gonna soak this, I don't know, 20 seconds, whatever. So 20 seconds, then you're gonna take this, and then you're just going to put this in and clean it. Do you want to take this around? So you're just going to clean it, and honestly, I do this for like maybe 20 seconds or so, and then I don't use that. So if you want to use these other ones, I don't put this back, and then I would use these extra ones to just go like this, okay? So after you do that, you want to try? Here, you can pass these around. Is there another kit? Oh, here. Can you pass it around that way so it's faster? So here you go. And these are the pipe cleaners. So it could be hard sometimes, but just, and then just the.
Use gloves when you're doing this.
Oh, you have gloves. Yeah, I just don't.
Okay, all
Yeah,
right.
I have my sterile gloves on.
You said
Sorry.
This is my dirty hand, this is my clean hand.
Oh, well, one.
wear gloves?
No. When, ooh. I mean, if you want to. I'm just
No,
kidding. No.
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 Have a glove.
Yeah, you can. Yeah. So she'll open the other trach care kit, and then you guys can pass it along. Okay? So after you do that, so let's say you're done cleaning the trach. So this is your sterile field. You can put anything that's clean here, right? Right here. So after you do that, you want to clean the area that's around the flange. So, and especially under it. Sometimes there could be drainage. You want to assess your patient at all times and assess them to see what color drainage it is. Is it green? Is it yellow? Is it pussy? Does it have foul smelling? All those are indicators for you to either like notify the MD and let them know, hey, there might be an infection going on of some sort. If there's excessive drainage, you also want to report that, and if it's reddened or swollen around the area, you also want to report that as well. Okay. If the patient complains of pain, you also want to report that. Those are just general signs and symptoms that we need to report, right? Okay, so the best way to assess is to actually look at the back. There's a lot of people, even in the hospital, they don't even look at the back of the flange, you know? They just clean, 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 but you want to assess to see, look to see, you know, take a flashlight maybe and look around and see if there's any, you know, any drainage. So this is what you clean, yeah?
Isn't it normal to have a little drainage?
It is, but you want to take into consider, like I'm talking about excessive drainage. You want to take into consideration the color is most important. Shouldn't be green, shouldn't be yellow. Clear is fine. It's probably just, you know, normal drainage, right? So you want to clean this. Again, this is not with the 50/50. This is just with normal saline or soap and water, okay? Do you guys have normal saline on hand? Just
That's what we use.
that's what you use. Okay, to clean it. Okay, perfect.
Or a G2. No, it's not for that, but
Oh, you can use that too. Yeah. Yeah. So if you have it on hand, if not, if you don't have it, soap and water is good too. Okay. Preferably it's saline. Okay. Thanks. All right. So then you get 3 of those, and then you want to just clean the area, inner, outside of the flange. Get your soap and water or your saline, dip it, and then you want to, so this is your flange connected to your neck, right? You just want to kind of go around here, right? This, yeah, the back of it. So this one is not like completely, they're not sutured. Your patients aren't sutured, though most of the new ones are sutured, and you only really see that in the hospital. So it's hard to get back there. But your patients aren't sutured. So there is room to move this flange right here, and it's pretty flexible. So then you just go around there and go and you assess. Go like this, okay? Right there. And so that's as far as cleaning. Now, as far as suctioning, how do you guys suction your patients? You have the trach and the mouth, okay. So you connect it to like a suction machine? Okay. So how long you want to take, you don't want to keep suctioning, right? You want to give them like 10 seconds in between, yeah, to catch their breath, because it's pretty traumatic, you know, to keep shoving a tube down their throat, and then, because they lose a lot of oxygen, yeah. So, but the fact that they're on room air is really good, because, you know, they're like breathing like you and I, right? Oh, yours is not. Yours is connected to oxygenate them. So they're connected to a ventilator?
Yes.
Like a portable ventilator?
Yeah.
Oh, perfect, okay. So yours would act differently. So when you're cleaning, because they're not on room air, you don't really want to take your time, right? Yeah, so.
The mom prefers I just change the tube. If it gets clogged and dirty.
She provides you with extra cannulas. That's even better. So that's what we normally do in the hospital. I'm gonna be honest, we don't really use this. The inner cannula? Okay, so the inner cannula, so this is the whole trach. So pretend this is in my throat, right? The inner cannula is this thing, is the one that comes out. Okay, this is called the outer cannula. This is the flange, and this is the inner cannula. So this is the one that comes, if you're lucky, the families will provide this for you. But honestly, I think these are pretty expensive. I don't know. I don't know how.
The insurance provides it for her, I guess.
Oh, that's perfect. Okay. Not all insurances do. Yeah, so that's a good thing. So, but yeah, so these, I'm teaching, don't do that. I'm teaching, that's really dirty. So this, this is disposable. Some of these are disposable. I think what you guys use is Portex at a facility. Is it Portex?
I think so, yeah.
Okay, so yeah, most facilities or most people that go home use a Portex. Most people that are in a hospital are Shileys. So we have different ones. So just make sure when you get a patient that what you're replacing it with is the same one, because you don't want to lodge something in there that's not the same one, right? The size, it'll tell you right here, the size and the brand or whatever. But this is the one. This is the inner cannula. So you can either clean this, like how I showed you here, or you can totally replace it and eliminate this whole thing right here, if the insurance, you know, is generous enough to cover it for you. Okay, so when you suction your patient, because you have to pre-oxygenate, you can't take that much time. Do you connect the tube back? So let's say you take this out, right? So you take this out, and then what do you do next?
Well, first I have to take off the oxygen mask that's connected to that. And
So they have like a aerosol mask that goes around here? Okay,
with a little hole in it, and then so that's, I can use it to go through the oxygen mask, or if I do need to remove that, then I just kind of take it off for a couple seconds, you know, twist it, take it out, reconnect it, twist it back in, and then
perfect.
put his oxygen back.
Yeah, that's perfect,
And
yeah.
then use gloves the whole time.
Yeah, so, yeah, you're doing it right. So, it's no different.
That doesn't get changed often. It's just depending on if something gets stuck, lodged in there, like a piece of, like, you know, like gas.
So the inner cannula, you don't, the facility doesn't require you to change it every day?
It's at his home. No, well, the mom does. So when I get there, just in case it does get lodged or whatever, then it gets removed. But it doesn't. She's the one that usually does.
Yeah, once you go home, sometimes, you know, a lot of families, this is costly, like, you know, sometimes it's out of pocket. They don't change it very often, but honestly, if it's nice and clean and, you know, and nothing gets dislodged in it, then you really don't, you know what I mean,
She
at
has
home.
some drawers and stuff, but like a lot of
To
all that stuff.
clean, yeah, so she probably does it on her own. Yeah.
So what's the recommendations of should it be done daily if you have it?
So in the hospital, so it depends. So in our hospital, we change this every shift. So every 12 hours, we have to change this or we have to clean it. Yeah. But again, it's different when you're going home. You know what I mean? Because money comes into play and stuff like that. And it's really dependent upon your facility. Well, what does your facility say? Like if for someone here?
As far as
How often do you have to clean or change this? I don't know.
it depends on what they instruct us at the home.
Oh, with the family. Yeah, so again, when they go home, it's a whole different deal. I don't know.
We don't do that here in the facility.
Oh, you do it at their house? Oh, okay, I get it. Oh, okay.
We mostly service people at the residence.
Oh, okay. I'm sorry, I didn't know. I thought it was everything was done here. Okay, yeah. So it's really at the discretion of the family, right?
Yeah.
So whenever they say, can you change it for me? Then change it for them, I guess. I don't know. They're probably the boss, I don't know. But at the hospital, because they have stricter rules there and, you know, like infection, you're around like 10 million sick patients all the time, and they just, you know, it's preventative. You have one sick patient at home. How infected can they get from another person who's probably healthy? So, and I think that's why they probably do it more often at the hospital. But yeah, so that's the cleaning part of it. What else? So do you have any questions in regards to cleaning? No, no.
So if you were gonna take it out and clean it, like on your shift, is it again the hydrogen and water thing, same thing?
Yeah.
Same way, just like?
Yeah, so that's, you put the 50/50 solution here. Yeah, and then what I like to do is like, again, like take off the cannula, put this, and then you could even just stick this in there and let it soak, you know? And then proceed to do the cleaning, you know? And you just sit there 20 seconds and kind of do it. I just use 20 seconds as a general rule for everything, so I don't know, just to remember.
You have little lines where it tells you how much to fill.
Oh, here?
Yeah.
No, no, there isn't any.
So, do you see what's being covered?
Yeah, it's just a general, like 50/50. You can use a measuring cup or a little cylinder that has a graduate, like measuring, if you want to be like super accurate, you know, but it's generally 50/50. Okay, so that's trach. You want to watch the video?
It's actually
Sterile supply for tracheostomy dressing change. She is removing the old dressing and is discarding it appropriately. She will wash her hands and don sterile gloves. She arranges all the sterile supplies, and with a non-dominant hand she will pour saline and hydrogen peroxide into the trays. She will remove the old inner cannula and discard it. If it is a reusable cannula, it will go into the hydrogen peroxide bath. With her sterile hand, she is grasping the new sterile inner cannula and replacing it securely. If this were a reusable inner cannula, the nurse would clean it in hydrogen peroxide and using a cotton tip applicator to get to all the crevices, rinsing it in saline before replacing it into the patient's tracheostomy tube. With a hydrogen peroxide soaked 4x4, the nurse is cleaning the area around the tracheostomy carefully and is repeating this with a saline-soaked 4x4. She will use a cotton tip applicator to get to the hard-to-reach crevices. She now carefully dries the area with a dry 4x4 gauze pad.
separately.
Yeah,
Okay?
you don't have, you could just put them all in one. Yeah,
This is like
it's
small.
easier. Yeah, I don't
Do
know.
that, you have to do it twice.
Yeah,
One thing then the other.
yeah,
It's
no.
okay to mix it.
Yeah, yeah.
When you take the thing out, the main one, does that usually or?
The inner cannula?
Yeah, does it start closing up?
What, your,
On most of the patients, because I know that with Mike.
oh, you mean the stoma?
Yeah.
Oh, no, no, because you still have the outer cannula inside of them.
No, the outer one usually, when you have to change that.
Oh, when you have to change that one, you gotta do that fast. You can't,
Because that starts closing up, causes bleeding.
yeah. So when you do that one,
Normal because my patient, or my client, he bleeds a lot right after.
so if you are, do they let you do
The
that?
parent does that.
Yeah, so,
Thank
yeah, that one, even in the hospital setting, I'm gonna be honest, we don't take that thing out, you know? Yeah, like, we just leave it in there. There's really, like, how often do they take it out?
Every, I think every month.
Yeah, because your stoma, if you take the outer cannula out, that's what's holding your stoma open. And a lot of times, like,
Tissue starts building around it.
it does, yeah, and then it causes bleeding, and then so you're constantly having to suction and worry about trying to clean it, and that's a lot of work,
Because
yeah.
when I come back after she's had to do that, she always warns me, be careful, there's a lot of blood, and it's gonna have a lot of pain, so try to,
Yeah.
be a little bit more gentler and not suction as deep.
Mm-hmm. Yeah, yeah. Yeah, and the most important thing when you're suctioning is to give them time to breathe, when you're suctioning the patient.
Is it normal or is it advisable to change every month?
Honestly, it's at the discretion of the family, but we don't do it. Well, I'm at the hospital, we don't even do that, you know what I mean? So, I don't know if maybe the doctor told her she needs to do it once a month. I don't know
I'm
the,
not exactly sure if it is once a month, but I'm guessing because I don't see it. I think that's what she told me, but I can be mistaken.
the only time I would do that is if there's a doctor at the bedside.
Yeah.
Like, because,
And what she did say was that she needs to change it because of that reason, because of the tissue building around it. You don't want that to happen, so you have to kind of change it.
Don, this thing would do that, remember?
Yeah.
It would start to,
Yeah. Tissue starts
So you guys had to change it too?
so you'd have,
No, we didn't.
We never did it,
The mom
but,
would, yeah.
Yeah.
the parents.
It's better now.
Yeah.
it's,
I helped the Renatas, I remember the mom do it once to take the whole thing out. But it was kind of, I was like,
yeah. Sometimes these families are more like, knowledgeable than an actual nurse.
She's very like.
She's comfortable with it. Yeah.
She does go
comfortable.
Yeah, because they're around it all the time.
They've been doing it for years.
Yeah, so they're more familiar. Yeah. So honestly, we would only do it if the doctor is at bedside, but.
And then that parent, I would watch how she worked with her daughter.
Uh-huh.
And then I had another person that, participant that I was gonna work with that helped me to help this lady because she needed similar things done to her
Uh-huh.
to assist her. So I told the mom, I go, you help me with my other person. I go, watching you help me to help that person.
Oh,
That
that's
people
good.
their
That's
child,
good.
Yeah. So, and some of the families say, oh, you know more than I do. And I'm like, no, sometimes you guys know more. because
Yeah.
you're the ones that-
Yeah, they
and
do.
if you show us, then we'll learn from you. Sometimes I'd rather have the parent or whoever's working with them because they do it more often.
Yeah, they're around it all the time,
Yeah.
so they're more comfortable with it for sure. Yeah. That's good. So, any other questions? We could do G-tube now. Gastrostomy tube? Okay. So, I couldn't find a G-tube. I'd have to go to like OR or something. But I got a Foley, which acts like, so I'm gonna pretend this is my G-tube. And this is your syringe giving meds. So how do you guys, what do you give meds through it and you feed them through it? Now, do you feed them by gravity or through a pump?
We use a pump, we also hydrate.
So you use the plunger and then you push or you take the plunger out and then you do it by gravity. So do you do this and you go like this and then you pour?
No.
I've done that.
You've done this, okay.
I've done it too.
This, okay, how do you do it?
I've never seen that, we use the plunger.
Oh, you just use the plunger?
Yeah.
So you go like this, so you have the Ensure or whatever, the
No,
formula?
no. The Ensure is going through a pump.
Oh,
We just
so you have a
hydrate.
pump.
We just hydrate, yeah.
Oh, perfect. Okay, so that's like at the hospital setting. So we don't really do gravity at the hospital, but we will come across it because sometimes you guys don't have the pump, right? They're not on continuous feedings. A lot of these people just don't have 24-hour feeding, right? No?
Yeah,
Mine does.
the one that I-
Oh, yours does?
But the family, the parent also does that too. They take care of that.
Yeah, and then
Machine
some,
gets set up to stop and then feed and stop.
And stop and feed. Yeah, I know, these machines are wonderful. They just eliminate our job. Yeah, I know.
Just in the time, I don't know, they really changed.
Yeah. So back then, we used to do it by gravity. And we would have to sit there and wait until this feeding would go in, go like this, go like this, go like this. You know what I mean?
Yeah.
So, do any of you guys still do that? Or do I have to go over that?
I've seen that done where they They feed them, they insure.
And then lift it up.
Yeah, that's
Yeah.
what- that-
I do that up until recently.
Oh, really? Okay.
Clean it with some water.
Yeah.
Mm-hmm.
Yeah.
Okay. So we'll go over both. So bolus feeding. So bolus feedings is the one where you do this. So it's not through a pump. So what you want to do, so pretend this is a G-tube. So again, you would do the same thing, the same procedure like you would do, like you wash your hands, don your clean gloves, and then introduce yourself, tell them what you're about to do. Because do you guys push meds through it too? Yeah? Okay. So how many meds can you do? How many can you crush together? It's probably a trick question.
They would just give me one to give.
Yeah, so it's only one.
Yeah.
Yeah, you'll be surprised because a lot of people mix 10 of them in there and try to create another drug and try to push it in. The stomach doesn't absorb very well the medication, and sometimes it ruins the half-life of the medication when you do that, when you mix it with other medications. So what you want to do is you always want to push one medication at a time if you have multiple ones. And you also want to flush before and after. So when you're feeding a patient, whether it be bolus or giving meds in between, flush. A general rule is always 30 and 30, 30 and 30. So 30 before and 30 after of either sterile water. You can use tap water. You can use, I don't know what you guys use, but at the hospital, sterile water?
Yeah.
Okay, so if they provide sterile water for you, it's best to use sterile water. But in an emergency case, like you can use tap water, or bottled water. Yeah. So, so 30 and 30, meds and feeding. So when you do bolus feeding, so you have your syringe. So let's say you have like all of your equipment. This is not a sterile procedure, by the way. So I normally just lay out a chuck. I have my syringe, my sterile water, my feeding, or whatever, insure. So you want to take your plunger and you don't want air. The most important thing that you don't want to do is introduce air because it makes the patient very bloated and gives them cramps. So what you want to do is what's called priming the tube. So when you prime, when you're attaching this, you want to fill this, you want to check residual, I'm sorry. Before you do anything, you always want to check residual to see if they're retaining any residual from the last time you fed them, whether it's continuous or bolus feedings, okay? Because believe it or not, bolus feedings, if you have malabsorption, like they don't absorb very well, they will retain feeding. And a general rule is, let's say if you get, I think it says in the packet, 200 or above cc's, 200 of these, so there's 70 in here. If you get 200, you want to stop, hold, and call the physician, right? Okay, so when you check residual and you get like, let's say 20, do you throw away the feeding or do you push it back in?
Throw it away.
No, because that's their nutrients. Yeah, so you always never throw their feeding. Let's say, even if I got, let's say 180, that's a lot, right? You push that thing back in because those are all of their nutrients that they need in a day, right? You don't want to deny them of that. So you want to push that back in, hold it, call the doctor, okay? But you never throw their feeding away, okay? So let's say I got 30 residual. So you push that back in, right? So you want to prime the tubing, so you want to get your sterile water. So you can draw it up if you're able to draw it up, right? And then you attach this, and then let's say there's water in here. You go like this. I do it to where I have like 10 or 5 cc's. Yeah, I don't push it all the way in because then you have air right here. You're introducing air. So what I do is I draw it up, I put it in here, and I go all the way to like 10. So you still have some in there. So when you do that and you want to do your bolus feeding, sometimes there's a little clamp here. You want to clamp it off because if you have it on and you take this plunger out, all that goes in there, then you have air, right? So you leave this in here. You always want to clamp first before you take your plunger out. So you clamp. You can do it with your hands too. You clamp, then you take it out. So I go like this, and it's pretty flexible. You can just manipulate it to where you can go like this. So you have this clamped, right? You can take the tubing out, reattach it. You still have the water in here, right? Take your Ensure and you push and you put it in here. I always do half of whatever it is. The higher you go, the faster it goes into the stomach. The lower you go, the slower it goes in, okay? If you notice, you always want to assess your patient while you're doing this. So if they're in respiratory distress, if they're turning blue, if they complain of pain, you always want to go, you always want to either stop. If they're complaining of pain, just stop, okay? But let's say they're like, oh, it's like I'm cramping or whatever. You just slow it down. Just, you know, put it towards their, or put it lower, not higher, right? And then if they're tolerating it, go as high as you want, you know, because they're probably used to it, right? Some of the families probably push it in, and they don't even do gravity anymore. I think they just push it in. Or and then they have the feeding pump.
Yeah, and then when I flush it, I don't flush it with syringe, I flush it with just pressing the flushing.
The pressing, the flushing, yeah. Oh, that works even better.
Yeah.
Yeah. So I'm trying to teach you guys the old school way because I didn't even know if you had a machine or not.
Sometimes I do have to do that, like depending on like same things if the doctor's gonna come, she doesn't want to do the flushing machine, then I'll get like sterile water and then I'll do it with that.
Yeah. And the most important thing you want to remember is not to introduce air. That's it. So if you have the general rule, just keep in your head that to when you're pushing it in, yeah, do not put it all the way down because you're introducing air. Always.
Suction out, you need to make sure it's all the way down.
When you what?
When you're gonna like syringe it out of like.
Oh, to check for residual?
Yeah. No, like when, like for instance, me, when I give them the medication, it's already like mixed in with sterile water. So all I have to do is use that, and then I take it out of the like there.
Mm-hmm. But you always follow it with to flush it
with water.
Yeah.
Flush it
Mm-hmm. Yeah. So that's where your 30-30 comes into play, right? Like 30 before and 30 after. So you push the meds all the way in so they get the meds, right? And then when you do the 30, push in 20 so you're leaving, you know what I mean? So you don't introduce air, okay? So it says here, so always flush your feeding tube before and after each feeding, before, in between, and after giving medicine, before and after checking stomach residual. And if you're on a pump, you want to check it every 4 hours. Oh, I'm so sorry. So go all the way, they're not even, so go to gastrostomy tube and then it's the third page. It says flushing a G tube, flushing your feeding tube. It says always flush the feeding tube before and after each feeding, before and in between or after giving medicine. How many pills at a time? One. Before and after checking stomach residual, and every 4 to 6 hours if patient is on a continuous feeding pump. You want to check honestly, probably every 4. And you always want to have your patient at a 45-degree angle when you're feeding them because there's very high risk for aspiration. Aspiration is probably #1 killer at the home setting and in the hospital because that's when we introduce fluid feeding into their lungs. And but it seems dumb, but just sitting them upright can prevent all this. But a lot of patients die just from aspiration pneumonia. All that other stuff I think I went over. Do you guys want to watch a video? Oh, it says do's and don'ts. Can you guys want to go here? Let's do the do's and don'ts of because I think this is important. So do you guys see the do's and don'ts of G-tube administration? Okay, let's read. Oh, so you want to always check to see if the drug is to be given on an empty stomach or a full stomach. So with a feeding pump, you don't really need to worry, right? Or you can stop it, you know. A lot of medications like Dilantin, if your patients have seizures, the feeding can actually inactivate the Dilantin. So you want to hold the feeding 30 and 30. 30 minutes before and 30 minutes. 30 to 60. 30 to 60 minutes before and then 30 to 60 minutes after you give the Dilantin. So when the pill comes in maybe prescribed in a liquid form, that's a lot better, because a lot of these G-tubes, especially at home, get clogged, and unclogging it could be a pain, you know. What do you guys use to unclog a G-tube? Have you guys ever unclogged a G-tube? No, you've never run into that? I mean, if you have to. Cranberry juice works. Cranberry, hot, warm, I should say. So if you warm up cranberry juice and you mix it in with soda, because the fizz or the carbonation actually breaks up the particles that are inside the tube. So if you were to just use soda by itself, that works wonderfully. If you don't have soda, use cranberry juice, heat it up a little bit and push it through. It works wonders. Yeah, if you ever have to. Huh? What?
I said, is it okay to use diet?
Oh, I don't know. I don't think that works. No, diet sucks. Okay, let's see. So that's why you always want to see if it comes in a liquid form. Obviously, see if the pill can be crushed. A lot of them are extended release tablets or sustained release tablets or capsules that you cannot. Once you break it, once you crush it, it's ineffective. So you always want to make sure that the medication is crushable. Let's see. You never want to mix a medication with feeding formula or another medication. So that's always, that's why you give them one by one. That one I went over. Don't reclamp the tube after administering a medication without flushing it. This can cause it to get clogged. I think that's it. Okay, go watch the video now.
The first thing you'll do to start your bolus feeding is to remove the plunger from the
suspension tubing. Now you're ready to attach it to your feeding tube. If you have a regular gastrostomy tube, flush your tube with water. This will help to push anything through that might be stuck in the tube from your previous feeding. To flush your tube with water, remove the plunger from the syringe. Next, take your syringe and attach it to your feeding tube. Now, you'll pour in 10 to 15 milliliters of water into the syringe and let it flow through your tube. Now go ahead and grab your formula container. You'll want to shake it and clean off the top before you open it. With your other hand, slowly pour formula into the syringe. Allow it to flow by gravity into your stomach. It should take about 15 minutes to give yourself about an 8-ounce can of formula. You can speed your feeding up or slow it down depending on your tolerance. You're more likely to tolerate your feeding better if you're sitting upright during your bolus feeding and for at least half an hour afterward. So to make your formula flow faster, you can actually raise your syringe higher in relation to your stomach, or you can take your plunger and push the formula through. You can make the formula flow more slowly by lowering your syringe in relation to your stomach, or you can try taking only a quarter of the can or half of the can at a time with a few minutes break in between. You may need to slow down your formula if you experience nausea or fullness during your feeding. You may also need to slow down your formula if you have diarrhea or an upset stomach immediately after your feeding. Refrigerate any leftover formula for up to 24 hours, and remember to take it out about 30 minutes before your feeding. Cold formula can upset your stomach. For more tips and tricks on tube feeding, be sure to visit shieldhealthcare.com.
For reference, if you want to watch the video when you're doing it. And then just the last thing is G-tube dressing change. How often do you guys change it? Daily? Mm-hmm. Okay. Yeah. Mm-hmm. And then again, just like the stoma, you want to report any redness, pain, swelling around the stoma to look under there. And then you use the drain sponge to cover it. Honestly, the drain sponge, you don't,
The G-tube.
yeah, we don't even, like, after, this is only used, like, after they first get them, and then after a while, they don't even have a dressing, unless they have drainage.
I guess my client hasn't had it long, so we do that.
You do this? Yeah.
And there's always a little drainage, so it kind of has
It's
to be
no,
done.
yeah. So we actually, we don't even use this after, if they're an old G-tube, they don't even have dressing on there. Yeah, you don't even have this, so, which makes it nice, and you don't have to change it every time. Any questions? No? Okay, thank you.
Thank you.
Thanks.